Bismillahirrahmanirrahim. Today we will discuss the congenital lesions of the larynx, and then we will discuss the tracheolaryngeal trauma as well. First, congenital lesions of the larynx. The congenital lesions of the larynx, important ones are laryngomalacia, congenital vocal cord paralysis, congenital subglottic stenosis, laryngeal web, subglottic hemangioma, laryngoesophageal cleft, laryngocele, and laryngeal cyst. Laryngomalacia. Laryngomalacia is the most common congenital lesion of the larynx, producing stridor in infants. Pathology. There is excessive flaccidity of the supraglottic larynx. This supraglottic larynx is sucked in during inspiration, which results in stridor and sometimes cyanosis as well. The stridor increases on crying, and it will decrease if the child is placed in prone position. Diagnosis can be made with the help of history, physical examination, and investigation, especially the flexible or direct rigid laryngoscopy. The findings on laryngoscopy are elongated epiglottis curled upon itself. This is called omega-shaped epiglottis. Along with this omega-shaped epiglottis, there will be floppy aryepiglottic folds and prominent arytenoids as well. The treatment consists of either conservative treatment or surgical treatment. The conservative treatment includes antibiotics if there is associated upper respiratory tract infection. Condition usually disappears by the age of 2 years. The surgical treatment consists of tracheostomy if severe respiratory distress exists in the child. Now, in this photograph, you can see the big omega-shaped epiglottis. Again, another photograph showing omega-shaped epiglottis. Congenital subglottic stenosis. Congenital subglottic stenosis is declared when subglottic diameter is less than 4 mm in full-term neonates. Normal diameter of the subglottic area is 4.5 mm to 5.5 mm, or in premature neonates it is 3 mm. Normal is 3.5 mm in premature neonates. Etiology. Usually abnormal thickening of the cricoid cartilage or sometimes formation of fibrous tissue below the vocal cords in the subglottic area is seen in subglottic stenosis. Clinical features. Usually the condition is asymptomatic. The patient, that is, the child, will become symptomatic when he or she is having upper respiratory tract infection. The symptoms are dyspnea, stridor, and cough. Diagnosis is made by direct laryngoscopy under general anesthesia. Treatment. Treatment of subglottic stenosis is that many patients improve with the passage of time as the larynx grows. So usually we do not need any treatment. But sometimes the child may need surgical treatment. He will need surgical treatment when the patient does not improve with the passage of time. The surgical options then include repeated dilatation of the stenos part, surgical excision or carbon dioxide laser excision of the subfibrous tissue, and excision of the stenos part, and then end-to-end anastomosis. Now in this figure or photograph, you can see there is a pinhole airway in the subglottic region due to the subglottic stenosis all around this pinhole airway. Another photograph showing subglottic stenosis. The next important congenital lesion of the larynx is congenital laryngeal web. It is incomplete recanalization of the larynx by birth. Web is present usually anteriorly, mostly between the vocal cords with a posterior concave margin. The patient usually presents with respiratory distress, weak cry, or aphonia since birth. The diagnosis may be made by history, examination of the patient, direct laryngoscopy under general anesthesia, or flexible laryngoscopy under local anesthesia. Treatment depends upon the thickness of the web. If the web is thin, then excision of the web with surgical knife endoscopically, or the web may be excised with the help of carbon dioxide laser. If the web is thick one, then open surgery is advised. Steps of operation are tracheostomy to save the airway, second, laryngofissure, third, excision of the web, fourth, placement of silicone key in the form of McNaught keel, and fifth, keel is removed after 5 weeks of the operation. Now you can see here that this is the web anteriorly, this is the posterior part of the larynx, arytenoids, and airway in this area is patent. This is the anterior web. Another anterior web with posterior concave margin. This is the endotracheal tube being passed to intubate the patient while performing surgery on the anterior web. The next important topic to discuss is the subglottic hemangioma, a congenital condition characterized by hemangioma formation in the subglottic region of the larynx. The child remains asymptomatic up to the age of 3 to 6 months. After this age, the lesion starts growing in size, and so the symptoms appear. About 50% of the children also have associated cutaneous hemangioma. Presentation. The child usually will present with stridor with a normal cry, airway obstruction due to venous filling caused by agitation or crying of the patient. Diagnosis can be made by history, examination, and direct laryngoscopy under general anesthesia. Under general anesthesia, direct laryngoscopy, the surgeon will see reddish blue mass below the vocal cords. Treatment. It may vary from case to case. The patient may require tracheostomy and observation because most of the hemangiomas involute spontaneously. Sometimes excision of the layering of the lesion with the help of carbon dioxide laser excision or cryosurgery may be required. Similarly, steroid therapy may be advised to the patient. For example, dexamethasone 1 milligram per kg body weight per day for 1 week, followed by oral prednisolone 2 to 3 milligram per kg in divided doses for 1 year. Similarly, propranolol or indidol may be prescribed. The dose is similar to the steroids. This is the photograph showing you a reddish mass below the vocal cords. This is the hemangioma. Thank you very much.